Ladies and gentlemen, welcome. We now proceed to Symposium 18 in Hall B, dedicated to infectious diseases, which will be covering antimicrobial resistance, infections in the immunocompromised, followed by a case-based discussion. It's my pleasure to invite our chairpersons, Dr. Wimalasiri Uluwattage and Dr. Ananda Wijewickrama. I now warmly invite our chairpersons to introduce the speakers and panelists for the session.
Good morning. Welcome you to the session on Symposium 18 on infectious diseases. We have two speeches and then a case discussion. For the first talk, I would like to invite Dr. Somia Iqtadar. She's a physician, academic, and public health leader with over 2 decades of experience in internal medicine, infectious diseases, and healthcare system strengthening. She currently serves as the Associate Professor of Medicine in King Edward Medical University, Lahore. She had been the founding secretary of the Pakistan Society of Internal Medicine, and she has been serving in that position for last 5 years or so. And in fact, I must say she is the live wire of the society. And I had the pleasure of meeting her a couple of years back when she was working on dengue. She was the lead author of Punjab government official clinical SOP for dengue and COVID-19. And she had contributed to major textbooks, and her work has earned her Presidential Award of Excellence, Governor's Award, Health Icon Award, and the Charles Wallace Fellowship at Oxford University Institute of A. She's going to talk to us on antimicrobial resistance in Asia, challenges and the way forward. Over to you, Dr. Somia.
Thank you very much, Dr. Ananda, for your very kind introduction, and thank you to the Ceylon College of Physicians for giving me the opportunity to talk to all of you today. Ladies and gentlemen, do you know what is the loudest sound in the world? It's not a bomb. It's not a volcano either. It is silence. A silence, if not treated or heard, can cost us 10 million deaths by 2050. In the shadows, a deadly threat spreads, relentless. Antimicrobial resistance silently undermines the modern medicine's great achievements, threatening to reverse the decades of progress. As infections become increasingly untreatable, the question looms: will we unite to combat AMR, or will it claim more lives? The choice is yours. Ladies and gentlemen, my name is Dr. Somia, and today I'll be talking about antimicrobial resistance with a special focus on Asia and the challenges we have and the way forward to handle this challenge. Here are my disclosures, but I have no conflicts of interest for this presentation. So throughout the history, there has been a continuous battle between human beings and multitude of microorganisms that cause infection and disease. But with the discovery of the penicillin by Sir Alexander Fleming and its subsequent development by Florian Chain, there was a revolution in the treatment of infectious diseases, bringing down the mortality related to infectious diseases and thereby increasing the life expectancy. But just imagine antibiotics which protect us from these deadly infections if they stop working. Because right now, we are standing on the edge of the world where antibiotics, which are most trusted weapons, they've become silent. A scraped knee, a routine surgery, or a child's ear infection can get deadly again. And this isn't fear-mongering. This is science. Antimicrobial resistance is a silent countdown, and the clock is ticking faster than we admit. Over the next 15 minutes or so, we'll try to uncover why this crisis is everyone's problem and how we can rewrite the ending. So 1.14 million lives gone every year, not from wars or disasters, but from infections we thought we'd conquered. pneumonia, tuberculosis, sepsis, diseases once bowed to antibiotics, but now they laugh at us. And this is the AMR's body count. But here's what gives me hope. We are not blind to the roots of this crisis. Scientists are racing for new drugs, governments are tightening antibiotic policies, and farmers are rethinking how they treat infections in the livestock. We are trying, but are we trying enough? This is the question. Let's be brutally honest. Something's broken. Our systems, our habits, they're leaking antibiotics like a sieve, and microbes, they are learning, evolving, outsmarting us every single day. What are the challenges related to AMR? Let's have a look. Every day, we are making a dangerous mistake, prescribing antibiotics when they are not needed. These pills in the palm you see in the picture, they represent more than just medication. They're contributing to a global crisis of antibiotic resistance. And now, as the text warns, the mistake is coming back to haunt us. It's the time we confront this reality before it's too late. This is where the resistance crisis goes viral. Literally, crowded farms, stressed animals, and then antibiotics are pumped into feed, not to treat diseases, but to prevent it. And to fatten livestock faster, they're given antibiotics. And this keeps the profits rolling. We are using medicines as band-aids for bad farming, and microbes are taking notes. So where do most antibiotics go? Not to sick people, unfortunately. 70% are fed to the animals, like these chickens, and these breeding superbugs in our food. And these bugs, then they jump to us. And every bite risks the medicine that won't work when we need it. So can you guess how many years it takes to develop one antibiotic? Any one of you? Is it 2 years, 5, maybe 7? 10 years. 10 years of trial and error, 10 years of dead ends, and 10 years of pouring billions of dollars into research, only to maybe get one drug that might work. And 10 years to create a new antibiotic. And you know how much does it cost? See, this is the pile of cash. 1.2 billion US dollars. That's what we spend every year on antibiotics. Money down the drain, unfortunately, because superbugs grow stronger and then they become resistant. So your money is your risk, and we're paying for the resistance with our health. And you've just spent 10 years and $1.2 billion on a breakthrough antibiotic. And can you guess how long until the bacteria outsmart it and it becomes resistant? 5 years? Less? More? So 2 years. So 2 years before you finish paying off your car and the antibiotic has become resistant. These are haunting us with every new pill. So why the drought? We've picked the low-hanging fruits, actually. The soil microbes, our old allies, are tapped into labs, recycle the old drugs with tweaks like rearranging deck chairs on the Titanic. Meanwhile, the bacteria, they invent resistant genes. And they are like TikTok trends, I would say, fast, viral, unstoppable. And very few antibiotics have been developed in the last 20 years. Most new antibiotics are actually variations of existing antibiotics, and only 5 novel classes have been developed in the last 20 years. And here's the scary truth. Even in labs, we are running out of weapons. Only few new antibiotics truly work. While superbugs are getting stronger, the antibiotic discovery is limited, and whatever is discovered becomes resistant. In 2023, only 3 out of 43 antibiotics in development targeted priority pathogens. The rest, they were just like band-aids on bullet wounds. We are stuck in a loop of diminishing returns, and microbes, they're all laughing at us, and they are resistant. But what if we flip the script? Imagine a world where infections rarely happen, where vaccines block the superbugs at the door, where hospitals are designed to repel pathogens, where farms don't breed resistance, where we stop infections before they start. Prevention sounds simple, right? But building better hospitals, washing our hands, using clean needles, prevention is a privilege, ladies and gentlemen. Half of the world lives in gleaming cities with UV sanitized operation theaters. But what about the other half? They are fighting infections with muddied water and open sewage, and AMR doesn't care about borders. See this child? Basic needs missing: safe water, toilets, waste control, and superbugs love filth. Without these, infection prevention fails, and we are all at the risk. Think about the places we trust most: hospitals to heal us, schools to protect our kids, offices to keep us safe. But when hygiene fails, these places turn into factories for superbugs. An unclean hospital bed, a shared kitchen sponge, a classroom doorknob, tiny oversights with colossal consequences. These mats and blankets, 3.85 billion people walk into clinics like this. No basic hygiene, and germs then spread freely. We are all vulnerable. 3.5 billion people, that's not a number, it's a tsunami, a tidal wave of human beings forced to live without toilets or dignity. Half our planet wakes up every day to a brutal choice: drink contaminated water or die of thirst. But this isn't just a tragedy, it's a global lab experiment for AMR. Untreated wastewater, it's a genetic swap meet for the superbugs. Resistant genes from farms, hospitals, sewages, they mix freely. In year 2023, scientists found a resistant gene from last resort antibiotics in India's Ganges River. And in Detroit, aging pipes leak waste into the Great Lakes, the same lakes which are also supplying drinking water to 40 million people. So AMR isn't over here. It's in our backyards, our bodies, our DNA now. So we talked about human-made failures: greed, inequity, and short-term thinking. But there's another force turbocharging AMR, the one we can't ignore: nature itself. Natural disasters are AMR's accelerators. In Pakistan in 2023, floods submerged 1/3 of the country, mixing the sewage with, and the cholera antibiotics ran out. So resistant genes spread like monsoon rains, and as droughts push farmers to overuse antibiotics on the stressed livestock, the cycle further escalates. So nature isn't just fighting back, it's outpacing us. So picture this: millions of livestock cross border daily, and they carry invisible passengers which are resistant genes. And climate change is supercharging the antimicrobial resistance. Rising temperature means more antibiotics are pumped into stressed livestock. At the same time, melting of a permafrost is unleashing the ancient drug-resistant pathogens. And this creates a vicious circle: resistance spread on farms, and then jumping onto humans. We are not just fighting microbes, but the consequences of our own recklessness. The data from the leading experts is clear and alarming. AMR is not just a future threat, and it is present, and more so in Asia. This makes us all, the region which we are living in, the Asia, most critical battleground in the global fight to safeguard modern medicine. The drivers of AMR in the Asia are powerful, interconnected, and accelerating. A massive population boom is colliding with a projected 150% surge in the poultry production, and this will inevitably drive the antimicrobial use in animals by up to over 10%. And compounding this weak water and sanitation system, this creates a direct pathway for resistant pathogens to spread, making Asia acutely vulnerable to this silent pandemic. Asia faces the major catastrophic AMR costs as well. Millions are pushed into poverty by health spending, GDP decimated, and urgent stewardship, targeted financing, and regional collaborations are our only defense against this human and economic collapse. This is the report of the WHO, which is the AWARE report on antibiotic use published in 2022, and it uncovers a dangerous imbalance. In many Asian countries, there's an over-reliance on watch group drugs with a higher resistance potential that should be used sparingly. And this, combined with significant data gaps, is fueling the fire. The priority is clear that we must strengthen the stewardship and shift prescribing towards safer access antibiotics to protect these essential drugs for the future. Country-level data makes the crisis tangible in India and China, which shows alarmingly high use of watch antibiotics, reflecting the deep-rooted prescription practices. Even in Thailand and Indonesia, you can see the trend persists. This isn't isolated. It's a regional emergency. And shifting prescribing behavior towards access antibiotics is no longer optional. It's essential if we want a global health security in place. So over the 5 years, a clear and a concerning trend emerges. So watch antibiotics use is rising steadily across the Asia, while excess antibiotics are declining. And this dangerous shift directly fuels the resistance. Without urgent intervention, the trajectory will render our most critical drugs ineffective. Look at the figures. The AMR deaths will skyrocket across Asia, millions which are preventable by 2050. This looming catastrophe demands urgent action. Containment investment isn't a cost, but essential to avoid trillions of dollar economic collapse. And Pakistan faces a severe AMR crisis, intensified by climate disasters like repeated floods, which accelerate the outbreaks. The numbers are stark. Over 59,000 deaths directly attributable to AMR in 2019, and more than 221,000 deaths associated with it. Resistance to key antibiotics like third-generation cephalosporins, they exceed more than 50% in hospitals. So I would say Pakistan isn't just a hotspot, it's a warning signal for the region, unfortunately. Look at India, which carries one of the world's largest burden of antimicrobial resistance. The scale is staggering. In 2021, resistance was directly responsible for over 267,000 deaths and linked to nearly 1 million. Surveillance data from 2023 shows carbapenem resistance in nearly half of all Klebsiella bloodstream infections. And these figures underscore a national health emergency that demands immediate and coordinated actions. Coming on to Sri Lanka, it's facing a silent health crisis. Their new national strategic plan reports alarming antibiotic resistance across major pathogens, and the numbers tell an urgent story. A shocking 72% of Klebsiella pneumoniae infection are resistant to ciprofloxacin. Over 60% of E. coli resist key antibiotics. With more than half of deadly bloodstream infections are methicillin resistant, it signals a breaking point. Sri Lanka's data is all clear call for reinforced action. Look at China, which faces a massive AMR burden driven by its large population and complex healthcare landscape. Hospitals' data reveal persistently high resistance in critical pathogens like Acinetobacter baumannii and Klebsiella. The stakes are existential. 160,000 direct deaths and 710,000 linked to AMR in 2021 alone, with resistance raging unchecked. China's battle against superbug is now the frontline defense for global health security. Bangladesh, no difference, expanded AMR surveillance to 11 sentinel sites, yet data reveals surging resistance in Enterobacter, especially third-generation cephalosporins, with over 260,000 AMR-related deaths in 2019 and persistent high resistance in critical bacteria. This public health emergency demands immediate intervention. So the question arises, what actions need to be done now? Or should we wait for 10 million deaths by 2050, costing us trillions of dollars globally? Is there a solution? Let's deliberate what's the way forward. So the solution lies in the antibiotic stewardship. And we all know that we are lacking in it at the moment. According to CDC, it is the effort to measure and improve the antibiotics, the way they are prescribed by clinicians and the patients, how they use it. And according to WHO, it is a coherent set of actions which promote the responsible use of antimicrobial. The emerging threat of AMR is growing exponentially, and antibiotic stewardships are cornerstone to fight this global threat. See, the role of antimicrobial stewardship is to help all of us for the future needs of the patients and everyone else to use them with great caution. So antimicrobial resistance threatens our modern medical achievements. To address this crisis in Asia-Pacific region, there's a comprehensive approach which has been built on 4 core strategic pillars. First, surveillance and data integration to establish real-time monitoring. Then research and innovation, which drives the development of new antibiotics. And third, education and training implementation with standardized curricula and training programs. And fourth, and most importantly, policy and regulation, which creates unified guidelines and appropriate restrictions to ensure responsible use. Together with these pillars, we can safeguard the treatment for future generations. So I'll conclude here with the thought that knowing is not enough. We must apply, and willing is not enough. We must do. Thank you very much for your attention.
Thank you very much, Somia, for that excellent lecture. And we can take one question from the audience.
I think wonderful lecture, as expected from Somia. I just want to highlight that in these developing countries like us, in Pakistan and Sri Lanka, so the main use, of the antibiotic is with the animal and the agriculture side, which I think contributes much more to than the human health. So I think we need to improve in the poultry side and the animal side, because they, like in Pakistan, because we import most of the raw materials, so 90% of the antibiotic raw material that is achieved. And in one of my studies, which was published in PLOS ONE not long ago, where the salmonella infection, 60% of the strains were, and this study was all over Pakistan. So salmonella is really going to be a huge problem in the future. So I thought, and we need, if we need to curb the antibiotic resistance, as you so elegantly said, we must focus onto the animal and the agriculture.
Yeah. So as I mentioned, 70% of the antibiotics are actually given to the animals and only 30% to the humans. And then they develop resistance and then they jump to the human. And also very rightly said, in Pakistan, actually, the sad story is that for salmonella, there was 100% resistance to ciprofloxacin and third generation cephalosporin, leading to XDR, multi-drug, and then the XDR typhoid, which became the highlight and the top news of the medical news of the town. Sadly, we are all working, trying to work, but something is not working. And there is very little discovery of newer antibiotics. The older antibiotics with some tweaks are launched and then they become resistant. So this is really something which is very alarming. And this actually is the silent pandemic, which is costing us millions of lives. Thank you.
Okay, thank you very much. I would like to invite my co-chair, Dr. Ananda Wijewickrama, to deliver the certificate of appreciation. Yes, next speaker is Professor Brian Angus. Professor Brian Angus is the Director of Oxford Centre for Clinical Tropical Medicine and Global Health and Reader in Infectious Disease at University of Oxford. His current research focuses on clinical trials and vaccine development for Nipah, COVID-19, malaria, influenza, HIV, and enteric fever. At the Oxford, he's a clinical tutor in medicine, professor of practice in medical education, and director of graduate studies. His chosen topic today is infection in immunocompromised, diagnosis and management. Over to you, Professor Angus.
Thank you very much, and thanks to the organisers for inviting me to this very friendly and welcoming conference, particularly to Praveen. I think infections immunocompromised hosts really bring into focus what the previous speaker was talking about with antibiotic resistance. Mostly the thing that protects us, first of all, our own immune systems, and so patients who are immunocompromised don't have that barrier and are very dependent on some of the therapeutics that we have. So I'm going to talk, first of all, a little case history, and in order to fit this in, I may need to go fairly quickly. So in Oxford, we had a patient recently, 67-year-old man, who'd come from Nigeria to visit his daughters, one of whom was having a baby, and he felt unwell within about a week of arriving in the UK. Now, we often get a little bit worried about viral hemorrhagic fever, so we risk assessed them, and there was no risk for Lassa fever, which is the thing that we're particularly worried about. He had a 2-day history of fever, reaching 39.5. He'd had some paracetamol, and he'd also bought some ciprofloxacin over the counter from Nigeria, but he'd taken that and not felt better. He also had headache and some right-sided pleuritic chest pain. He wasn't entitled to free NHS care, which is something that was important in discussions with him. And as I say, we didn't think his risk of high consequence infectious disease, Lassa fever, as we would say it, was low as he visited the UK. His past history, and again, this is very pertinent and common in patients that we see. He had a live, unrelated renal transplant for autosomal dominant polycystic kidney disease in August of 2023 in Lagos, Nigeria. He also had some other things, hypertension, asthma, a thyroid swelling. He was a retired professor of ecology and a Jehovah's Witness, which again will become relevant in how things are developed. He's a non-smoker, no alcohol, and usually independent. He was taking some drugs, particularly immunosuppressives, mycophenolate, prednisolone, and tacrolimus, and had been taking some ciprofloxacin. Unfortunately, there is some interactions with some of these drugs. And he was not on any antibiotic prophylaxis, which is commonly given to patients' transplants. His renal background, which we went into in a little bit more detail, but obviously we didn't have that much information from Lagos, was that he had a living unrelated donor. The HLA and the CMV status of the donor were unknown, and he had been admitted to in the hospital in Nigeria because of T-cell mediated rejection on the scans and reduced renal function. And he'd been given a big dose of IV methylprednisolone, further immunosuppressing him. The diagnosis of T-cell rejection, he had told us it's usually made on a biopsy, but he didn't remember having a biopsy. And also this had led to an increase in his maintenance immunosuppression. When we saw him, he had bilateral basal crackles when he came into the medical take. He had a skin abscess in his left lower jaw that had healed and looked quiescent, wasn't tender, and other examination was normal. His blood test showed impaired renal function and a hemoglobin of 72, which is reduced with a sodium 116 reduced, and a raised CRP. We took some blood cultures, and in fact, this is his chest x-ray, and initially we thought there was some right upper lobe consolidation. We thought that he probably had a pneumonia. So he was discharged, in fact, with amoxicillin and doxycycline, which would be standard for community-acquired pneumonia with a low curb score. 6 days post-discharge, the laboratory flagged that his blood culture was growing nocardia, Syrace georgica, which used to be called asteroides, which is much more easy to say. So we called the patient up and we arranged for him to come back. And because he'd grown nocardia, we were a little bit worried that he had spread to other places. This is a CT scan, and it shows, in fact, those changes in the right upper lobe were much more extensive than we thought, with cavitation already happening. And when we scanned his head, we found, in fact, that he had cerebral abscesses that you can see in the MR. So summary of his investigations: multiple cranial abscesses and on MR and CT. We looked to see if we had any evidence of endocarditis, but on the transthoracic echo, there were no vegetations. Having grown the bug in the lab, we then looked to see the sensitivities. Nocardia, as I'll show you, are often resistant to lots of different antibiotics. You can see we compared these to the UCAST breakpoints for the therapy to try and guide things. So the clinical issues summarised at that point were he disseminated nocardiosis with bacteremia, lung involvement, multiple brain abscesses, and failing graft function. And he also had anemia in the context of his failing graft, and he was unable to have blood transfusion because of his religious beliefs. He also had some possible candidal esophagitis with some difficulty swallowing, and he developed diarrhea, which was C. diff positive. Again, very typical in patients who are immunocompromised. So we started on an IV meropenem as a sort of interim measure to keep things until we knew what the sensitivities of things were, and then we switched to IV cotrimoxazole. Unfortunately, when we did this, as is often the case, his creatinine rose again. So we switched him to ceftriaxone, again guided by the MICs. We were trying to arrange for him to have outpatient therapy with IV ceftriaxone twice a day, which we often do with our home IV service. Particularly this was facilitated because his daughters, in fact, were both nurses working in the hospital. We gave him some oral vancomycin for his C. diff, and he was starting some oral fluconazole for his oral thrush. And again, very typical of immunocompromised patients that we're having to use lots of different agents against lots of different pathogens. So his creatinine rose and his hemoglobin fell further, thought again because of sepsis and failing graft, but otherwise his electrolytes are okay. We did a scan of his kidney to check we hadn't missed obstruction, and we asked the renal colleagues to talk to him. They were a little bit concerned about fluconazole affecting tacrolimus levels, and so we switched to nystatin. They stopped the MMF because of the nocardia infection, but kept him on the TAC. And he continued on prednisolone. As I say, this is a background of someone who'd had previous T-cell rejection, so they didn't want to reduce his tacrolimus too much. We gave him some erythropoietin to try and help his anemia, as he wouldn't accept a blood transfusion. He was admitted on the 23rd of July, discharged on the 31st, so a week, on IV ceftriaxone and meropenem via his PIC. We arranged for an outpatient MRI scan, which was reassuring. We wanted to continue, again, for nocardia, you have to treat for a long time. So the combination IV therapy for about 60 days, and then we planned to switch to Coamox and minocycline for a year. The plan was to supply the minocycline and we would give him antibiotics to be able to take back to Nigeria when he went back. Unfortunately, his creatinine got worse. And we then checked for other reasons that his creatinine might get worse, and he also had BK virus. So he had 4.08 log 7 copies of, per ml in his blood, and the only treatment really for BK is to reduce the immunosuppression. So we started to reduce his tacrolimus, constantly measuring levels. In fact, the renal physicians wanted to do a renal biopsy, and when they did, they found florid BK nephropathy with inclusion bodies. No evidence of rejection, and so again, treatment was a reduction of immunosuppression, but they felt that actually they were already at this level. So in the end, the patient went back to Nigeria, so we don't know what happened. So nocardia, ubiquitous, saprophytic, lives in often wastewater, as has been mentioned before, common site for pathogens to emerge, and is partially acid-fast. It grows as these filamentous branching rods, and there are 4 common species: Nova brasiliensis, Farcinia, and then Cyrosea georgica, which was asteroides. It's usually identified on AFB and also on the gram stain with these branching beaded rods. Speciation is very important for antibiotic therapy, and we usually do sequencing of 16S RNA in order to speciate, so it has to go to a reference laboratory. Nocardia is worldwide, but particularly in temperate and tropical areas. True incidence of disease is unknown because diagnosis can be quite difficult. In high-resource countries, it's estimated about 0.3 to 1.8 cases per 100,000, and it's higher in immunocompromised patients. It's something always to think for. Say in tropical, low middle-income countries, the incidence is probably higher, but underreported because of limited diagnostics. And there seem to be some seasonal peaks, commoner in the warmer months in temperate climates. Clinical manifestations, the main route of inoculation is through the respiratory system, but you can also see people, particularly farmers, who get traumatic injuries with direct inoculation from soil. It's a subacute onset. It may well be that the healed abscess that he had in his jaw was the first signs of nocardia. Usually when it causes the respiratory illness, it's usually typical cough, hemoptysis, fever, weight loss with constitutional symptoms. And the one thing to remember is mortality, in fact, is very high. 55% mortality with cerebral infection. So lungs most common, extrapulmonary dissemination in lots of cases, although again, the data is a little bit difficult. And brain is the second most affected organ, and patients present with headaches and seizures. And then you see skin nodules and abscesses. This is a picture of primary cutaneous nocardiosis with extension into the muscle and into the pleura, in fact. So antibiotics are the mainstay, but they say there's a lot of resistance, varies with species, and it requires prolonged treatment, 6 to 12 months. Sometimes patients are given boosts to their immune system with interferon gamma, but again, there's no good evidence for that. And surgical debridement is often required as well, which can be quite extensive. There are no controlled trials for treatment regimes for nocardia, but usually Cotrim, carbapenem, and linezolid have been used in life-threatening situations, and again, no real data for this. The antimicrobial susceptibility, you can see asteroides is on the end, and you can see that it varies between species. Now, the things that are normally sensitive are things like linezolid, whose main complication is anemia, so we were really stuck with this patient, and amikacin, which main side effect is renal toxicity, so again, wanted to try and avoid. So the take-home message really about immunocompromised patients is it's the opposite of Occam's razor. So Hickham's dictum is that the patient can have as many diseases as they want, and this is true in immunocompromised patients. If patients have nocardia, then you have to think about lung and brain, and it's acid-fast like TB and has very high mortality. So just to summarize a little things in general, and I just wanted to have a little look at actually immunocompromised patients are increasing in number throughout the world. And so I'll do a little brief summary, particularly related to travel, because a lot of our patients who are immunocompromised are going overseas. So the main sort of thing that people recognize is HIV, and of course about 40 odd million people at the end of 2024. And then their primary immunodeficiencies. Difficult to know, and again, we heard about some genetic disorders this morning in Pakistan, and again, these primary immunodeficiencies poorly diagnosed, probably about 6 million in the world. And then secondary, so these are the things that medical interventions are causing immunosuppression. So active chemotherapy, there are probably about 11 to 12 million per year in the world who get chemotherapy that will affect their immune system. And then we have the solid organ transplants. And again, the chap from Nigeria, the Nigerian centre is one of the biggest centres for renal transplant in Africa. And I know there's an active renal transplant programme in Sri Lanka as well. So this is just breaking it down to region. But again, these numbers outside of Europe and North America are very sketchy. Diagnosis, particularly primary immunodeficiency, is very difficult. So the common pathogens, so they can be affected by anything, really. So bacterial, microbacterial, salmonella, as we mentioned before, but also other soil things like nocardia and actinomyces. The viruses we tend to monitor quite a bit, and we check for hepatitis, and we also tend to monitor CMV, very common ubiquitous virus. Fungal is becoming an increasing problem as well. And again, as far as antimicrobial susceptibility is concerned, the fungi are emerging as a real problem as well. So recent outbreaks of things like Candida auris, contamination of lumbar puncture, intrathecal chemotherapy, for example, with Aspergillus. And then parasitic, again, common in the tropics, particularly things like malaria people are more prone to, but also other things like strongyloides and leash. So there are lots of risk factors that come along. Some of the figures, as I say, for solid organ transplants, you can see that it's increasing year on year. And these are the estimates for the numbers in 2023, but there'll be much more than this now. The diagnostic challenges, particularly in the tropics, are that there's limited access to diagnostic tools. And when you're immunocompromised, of course, your immune system won't produce antibodies, so often serology is very unhelpful. So you really need to have an antigen or a nucleic acid detection system or culture systems in order to grow these organisms. And as I say, the diagnostics are often lacking. Often the patients present in an atypical manner. They don't mount fever sometimes. They don't have the usual presentations that we see. Co-infections, often patients have more than one infection. Again, very difficult to treat. And remember Hickham's diktat, they can have anything that they want. There is a need for rapid point-of-care diagnostics because patients who are immunocompromised deteriorate very quickly. So often they get empirical therapy, again, adding to the problems of antimicrobial resistance. So management strategies, really early recognition and empirical treatments. And everyone knows about how to treat neutropenic sepsis, and we have guidelines in order to do that. Prophylactic antimicrobials are used in high-risk patients, and again, we try and avoid these, but in patients who are immunocompromised, they may well be the last line of defense. We need to strengthen health systems and access to care and tell patients to come very quickly if they feel unwell. And there are guidelines from WHO and CDC for managing infections in immunocompromised hosts. And then one thing that hasn't been mentioned yet is vaccination. So we try and get ahead of things, so prevention is better than cure. So we have a system where we try and screen people. And of course, if you can do it pre-immunosuppression, then that's great. And we have a screening system looking for things like hepatitis B, hepatitis C, HIV. We also screen for tuberculosis. There was a talk a day or two ago about screening for latent TB. And again, if people are positive, then they can be treated for latent TB. And then there are other things that we consider screening immunocompromised patients, things like EBV, which is associated with lymphoma, CMV, which again is associated with things like hepatitis and pneumonitis as well as colitis, and then toxoplasma as well. We try and ensure that people are vaccinated before they're immunosuppressed. And so things like COVID vaccine, flu, pneumococcus, varicella, and meningococcus before therapy. And then think about trying to give prophylactic antibiotics. So the guidelines vary according to which sort of immunosuppression you have, and particularly related to things like risk stratification. So for stem cell transplants, for example, early on, it's very important to protect patients from the environment with HEPA-filtered air and positive air pressure, and then evidence-based prophylaxis and vaccination protocols. For HIV, again, particularly, there are lots of guidelines related to primary prophylaxis with low CD4 counts with co-trim, and then secondary prophylaxis according to what we find. And vaccination as well is important, particularly for hepatitis, pneumococcus, and Hib. There are some guidelines for immunocompromised travellers, so people who are going to areas with high risk of severe enteric infection, and of course immunocompromised patients are at risk, so things like Campylobacter, Cryptosporidium, Listeria, and often we get into a situation where people have intractable Cryptosporidium, for example, which is very, very difficult to treat, and often things that are very difficult to treat and take a long time lead to increasing problems with resistance. There's an increased vulnerability to fungal diseases, and particularly things like Thalassemia, penicillium in Southeast Asia, and coccidiomycosis in the Americas. There's also some evidence that people who are immunocompromised are more prone to arboviral infections. So things like rituximab that deplete B cells markedly increase the risk of fatal arbovirus neuroinvasive disease. And as I said, serology is unreliable. So just going quickly, some of the drugs, and I think this is a constantly changing landscape. Someone was saying this is a golden era in cancer therapy, but it does mean that there are more and more complications from cancer therapy as well. So things like steroids, good old-fashioned strong things, but of course it does make you prone to lots of different infections, and particularly the well-recognized strongyloides hyperinfection syndrome. And again, we're seeing this more and more. Calcineurin inhibitors like tacrolimus, again, opportunistic infections, CMV, BK, GC, pneumocystis particularly, but also other things like urinary tract infections, skin infections, and fungal. Sirolimus, mTOR inhibitors, again, widespread susceptibility to different infections. And then the antiproliferative and antimetabolites, again, common infections, but think particularly of Listeria, pneumococcal infections, as well as zoster and CMV. JAK inhibitors are sort of fairly new drugs that we use quite a lot during COVID, and again seem to predispose people towards pneumonia, cellulitis, and also particularly herpes zoster. And so we try and make sure that people are vaccinated against zoster beforehand. There are more and more biologicals and monoclonals, TNF-alpha inhibitors, particularly adalimumab, infliximab, and tesseract, as well as the B-cell inhibitors, rituximab, and they are prone to lots of things, but TNF-alpha inhibitors, particularly TB reactivation, other things like Listeria and Legionella. Rituximab, really viral infections are a particular problem, particularly HPV. So other agents, so new things come along, eculizumab, anti-complement, which seems to make people prone to meningococcal infection. And again, vaccination, very important. So vaccination principles, got to avoid live vaccines, of course, in immunosuppressed people, unless you can get them in before they become immunosuppressed. And it's important to make sure that you use inactivated vaccines that are known to be safe. We also vaccinate household contacts in order to protect people. So these are the vaccines that are recommended, and particularly, again, the new one in the UK, particularly is Shingrix, which is an inactivated varicella vaccine. For organ and stem cell transplants, there are lots of guidelines, and again, we often say to people to carry documentation just showing what vaccinations they've had, because we don't want people vaccinated at the border. Sorry, I'll move on. So other things just to remember, people are traveling, malaria prophylaxis, people who've had a splenectomy, had the spleen removed, they're at increased risk of severe malaria. Important to emphasize, like all travelers, food and water hygiene, because vaccine efficacy in immunocompromised patients against things like typhoid and cholera are uncertain, and try and avoid high-risk exposures, particularly animals. And very important, ensure travel insurance. As you can see from our patient from Nigeria who had no insurance, he ended up with a very big bill. So that's quite summary. I'd just like to thank people involved in the thing. And also don't forget about HIV, but also don't forget about other immunocompromised patients. And we saw that in COVID, where people who were immunocompromised were told basically they had to stay at home and shelter away from everyone else. And so that's the other important thing about vaccination. It protects people. If you get vaccinated, it protects people who don't have a good immune system from getting infections. Thank you.
Thank you very much, Professor Angus. May I invite you to take a seat in the stage, please? We are not allowing any question time after this, for the reason that the next part of the symposium is a sort of a continuation of the same topic. So the next, it will be a case discussion on infections in the immunocompromised. And for this, may I invite Dr. Chanaka Abeyratne, consultant nephrologist, Dr. Chula Herat, consultant nephrologist, and Professor George Alangaden is joining us virtually. And the session will be moderated by Dr. Lakmal Fonseka.
We have to be extremely thankful for Professor George Alangaden, especially he's joining us with, from Detroit, USA, and he's the Director of Transplant Infectious Disease at Henry Ford Health and Clinical Professor of Medicine at Wayne State University and Michigan State University. And Dr. Alangaden's clinical work and research is in the prevention and treatment of infection in transplant recipients and other immunocompromised patients. He's well published in these areas of research. Thank you very much for joining.
Yeah, thank you so much for the introduction. So it's going to be a complex case that we are discussing today, mainly seen by Chanaka. And Chanaka, I invite you to start the presenting the case.
Yes. So to set the stage for today's discussion, I would like to start with this case. So this is an infection in the immunocompromised patient. He's a 50-year-old male patient. He had a long history of diabetes and hypertension. So 15 years. He defaulted follow-up before the transplant, had a transplant 6 months back. It was a live donor transplant and uncomplicated. There's no surgical or the immune-mediated complication during the transplant. The immunosuppression was maintenance therapy with the tacrolimus, MMF, and prednisolone. At 6 months after the transplant, he came with fever for 3 days, a high-grade fever, progressive shortness of breath, and respiratory distress. On examination, he was dehydrated, he was in respiratory distress, tachypneic, and tachycardic. Blood pressure was slightly lower side with 100/60, and saturation was 88 on room air. On lung examination, there's a bilateral Krebs in lower and middle zones. So the investigation revealed elevated white cell count with elevated CRP. Creatine was baseline was 0.8. The graft was perfect up to the 6 month, and there was graft AKI with jump of creatine from 0.8 to 1.5, and electrolytes panel were normal at the time of admission. The arterial blood gas revealed significant hypoxemia with severe acidosis. Bicarbonate was 15 with it's a combined acidosis with lactate-driven acidosis plus ongoing acute kidney injury plus background sepsis. So chest X-ray revealed the bilateral patchy infiltrate basically in the perihilar region but involved in all 3 zones. So this was our initial management. He was very dehydrated. He started IV normal saline, and he didn't. For the oxygen therapy, he started initially CPAP and then the intermittent CPAP plus high flow. All the cultures sent blood, urine, sputum, early HRCT arranged. With the background history of immunosuppression, we were forced to start broad spectrum antibiotic, IV meropenem and teicoplanin. Immunosuppression, MMF withheld, reduced the dose of tacrolimus, and prednisolone dose escalated.
Yeah, so we have come across a patient who has undergone a renal transplant 6 months ago and on immunosuppression at the moment. And the impression is the patient is having a febrile illness with lung infiltrates, hypoxia. So it's likely a pneumonia that we are dealing with. So if you are seeing this patient bedside, I would like to ask from Prof. Alangaden, how can we approach this kind of patient, digging deep into the history and examination, and what are the initial steps that we should do in that eliciting the clinical features?
Hi everyone, I hope you all can hear me.
Yes,
First
we
of
can
all,
hear you.
good morning to all of you all, a good afternoon. It's about 2 years, so I'm wide awake still. And I just want to take a moment just to thank the organizers of the Ceylon College of Physicians for this invitation, and all of the Dr. Fonseka and Abeyratne for putting this great case together. I'm glad that Professor Angus went just before this because it segues very nicely into this case. So when presented with this case, as you summarized, it's a 50-year-old male who's presenting 6 months after a kidney transplant with an acute onset of fever and rapidly progressive respiratory failure. And on his chest X-ray, what you see is patchy bilateral infiltrates. So when approaching this, sometimes it can seem very overwhelming because this is clearly an immune suppressed patient, but we could break it down by stepwise. First is to understand how immune suppressed is this patient. And some of the pertinent things you might want to ask is, what was the induction done for the transplant? Frequently, kidney transplant patients get ATG, which is a very severely suppresses T cells. So these patients are at great risk for intracellular pathogens, which are predominantly viruses, fungi, and maybe things like Legionella, Listeria, and so on. The second thing is to understand whether there were any acute episodes of rejection that needed intensification of the immune suppression and subsequent. And one more thing sometimes, which might be a clue, might be the degree of lymphopenia, which often sets them up for infections such as pneumocystis and CMV. Like Dr. Angus mentioned, it's important to understand the pre-testing serostatus, particularly with CMV. Was this a high-risk patient where the donor was positive or the recipient was negative, or is it an intermediate risk where the recipient was positive? It's also important to know, did this patient have any testing for latent TB infection? Were there any prior X-rays that showed any abnormalities of previous granulomatous disease? EBV toxoplasma status. We also screen for strongy because that can sometimes show up. And then important to understand, was this patient vaccinated pre-transplant or even post-transplant against pneumonia pathogens such as influenza, COVID, and pneumococcus. Post-transplant, all of these patients get prophylaxis predominantly with trimethoprim sulfamethoxazole, which protects against pneumocystis, and as well as maybe toxo and nocardia to some extent, and valganciclovir, which protects against CMV and HSV. So it would be important to understand for how long did he get this prophylaxis and when was it discontinued. It's also important to understand the post-transplant course. Was it a stormy course with a lot of infections with MDRO bacteria, MRSA? Were there any breakthroughs with BK or CMV? Because that will give you a clue as to how immune suppressed this patient is. And then finally characterize this infection. As with any pneumonia, we always ask a history of any sick contacts because these are community respiratory viruses. Any unusual environmental exposure related to soil, which could set you up for nocardia molds, water, which is an important thing here for us because of Legionella. And then what was the presentation? As we heard, it's acute onset, not a subacute process. There is fever, but there is no cough and there's no sputum production. So predominantly in this patient, you're dealing now with an interstitial lung disease rather than a parenchymal disease with productive pneumonia and things like that. So I would say thinking of it is appropriate to start broad spectrum antibiotics, but it's very important to understand there may be more than one infection, namely an opportunistic infection that's capable of causing interstitial pneumonia. So that would be the way I would approach this case and direct my diagnostic workup and the management.
What's your impression about the chest X-ray findings? Can we go to that slide, Chanaka, and Prof can comment on that?
Yeah, even though I can't see it very well from here, but I've seen the X-ray before. So I would say it's a bilateral. To me, it appears more like interstitial with possibly some nodularity. It's predominantly affecting the middle and lower lobes. There is no associated pneumothorax or pneumonia or pleural effusion. I don't see any lobar consolidation. So my concern for a typical bacterial pneumonia is low. But the risk for interstitial pneumonia, such as pneumocystis, CMV, respiratory viruses, is higher. It's very hard to tell from an X-ray because it might underread some of these things. So I guess you'll be moving on to getting as you said, a high resolution CT scan to better characterize these infiltrates.
Yeah. So Chanaka, could you brief about the further investigations that we got?
Yes.
Information, sorry.
Yes. As Prof. Alangaden asked, so the preoperatively the mismatch was 110. The tutors also would agree with us. It's a fairly good match. The CRF means cumulative reactive frequency, that means antibody screening of the recipient because he has not been sensitized previously. So there is no detectable HLA antibodies, so that indicates the degree of immunosuppression in the post-transplant period. The sero status of the donor and recipient both were CMV IgG positive, so that falls under the category of intermediate risk of CMV reactivation after the post-transplant period, and the EBV IgG positive in the recipient and IGRA was negative, and we routinely are doing the MRSA screening before the transplant. The swabs of the groin, axilla and the throat all were negative. So induction done with equine ATG. He's 50 years old age, though the CRA was 0, there were no antibodies. He had 2 blood transfusions, so we were forced to go ahead with the equine ATG and 2 doses of IV methylprednisolone pulses at the time of induction. Post-operatively, no post-operative admission secondary to the rejection, no infection. His graft function was perfect throughout the 6 months. Cotrim chemoprophylaxis was given and valganciclovir given for 3 months, 100 days. At the 3rd and 6 months time, blood BKV was negative, so that indicates a degree of immunosuppression. So there were no detectable BKV, and CMV negative at 3 months. Blood CMV PCR was negative. The last TAC level was 6.5 nanograms per milliliter 1 week back before this admission.
So this patient is off prophylaxis at the moment, isn't it?
So the prophylaxis stopped, the Valgan stopped at 3 months according to the guideline. And no, he was on Cotrim prophylaxis even at the time of 6 months, but off Valgan. for
Yeah.
disease.
So, Prof. George, if we think of the differential diagnosis here, from the information what we have, how can we prioritize our differential diagnosis?
Is a question for me?
Yes, yeah.
Okay, yeah. So I think, the information so far, we do realize he's not on any prophylaxis for pneumocystis. So clearly that moves up on the list of potential causes of interstitial pneumonia. We also know that CMV, even in intermediate risk patients, can reactivate at times. So the fact that is post-valganciclovir prophylaxis also increases the risk for CMV reactivation in this patient. So I do think that would be a very important piece of information, knowing the serostatus as well as a prophylaxis. So I think as we move along, I would certainly look at the two most common, I would say three most common would be respiratory viruses. You have excluded, I think, from what I can tell, you may have had the COVID and influenza test back by now. So that would rule out those two. There are other viral pathogens, but I think the rapidity of progression really makes me think more of pneumocystis in this context that is driving the process with a dry cough, with maybe CMV might be contributing, but in kidney transplants, almost 80% or more of CMV or end organ disease occurs in the gut. So they get gastroenteritis rather than pneumonitis, which seems to be relatively uncommon in kidney transplants compared to the lungs and other transplants. So I do think pneumocystis is an important thing to kind of exclude, and a lot of our diagnostic strategies should be directed towards the diagnosis of pneumocystis.
Yeah, next I would like to ask a question from Dr. Chula Herat. So other than PJP and also CMV infections, any other differential diagnosis that we can entertain, especially when it comes to tuberculosis? And if you can comment on how many of tuberculosis patients in renal transplant recipients that, that you have seen as well?
Pneumocystis and CMV are the first things that come to my mind, at 6 months and 2 months after stopping prophylaxis with cotrimoxazole and valganciclovir. But we have seen COVID and influenza present in the same way. Those two are possible, but I think tuberculosis may be a little too early, but it can happen. It doesn't look like a miliary tuberculosis anyway, that chest X-ray, but you have to exclude. You said that you have done the TB tests, gene expert, that has come as negative. So I would say the four things that I would think of is pneumocystis, CMV, and the two viral infections, influenza or COVID. Those are the common ones that we'll have to think of.
Yes, thank you.
There are so many other rare infections, but I think at 6 months, I don't think we have to think of them immediately unless...
Can I just add, one of the other differentials that people often set on is cardiac failure. So cardiac failure can look very like this on chest X-ray. And often we've seen patients before that the acute medicine team have thought they were fluid overload because of the kidney transplant and treated for cardiac failure without thinking about PJP.
Prof. George, I want to ask another question. What are the targeted investigations? So we have projected some of the investigations that we have done at the moment, but overall, what are the targeted investigations that would you do at this stage?
Yeah, so I do think, you have obtained blood cultures because that should always be done for bacteria. So I'm glad, hopefully those are negative by now. You have sent off sputum for gram stain cultures, but sputum should also be sent, since you're thinking of these things, you should send it for a pneumocystis PCR, which is relatively definitive test. Yeah. So certainly you want to send sputum either if he produces it or induce it and send it for a pneumocystis PCR, which should give you the diagnosis very quickly. You should do CMV in the blood because even though there is some discordance between CMV-D anemia as an end-organ disease, almost always, if there is end-organ disease, you will detect it in the blood to some level or so. And you can see that that's there. In addition, I think once you do the viral workup, if you're really concerned, if there was some sick exposure and you think of other viruses, you could consider doing a respiratory viral panel, which has a more expanded axis looking for parainfluenza, adenovirus, and other things like RSV, which sometimes you can look at. We would also look for Legionella, even though it's not the classic presentation, and I don't know if Legionella is very common in Sri Lanka, but during summer, that's pretty common here. So we would have directed our initial approach also to exclude Legionella, doing a urine Legionella antigen. That would have been what we would have done over here. As far as the rest of the workup, I do think a high-resolution CT scan is very critical to define these abnormalities, because sometimes they might have a mixed picture, not just ground glass opacities consistent with pneumocystis, but pneumocystis itself can have nodularity and other things. And like Dr. Angus stressed, in immune-compromised patients, they are not mutually exclusive. They can have several things, and particularly when you have CMV reactivation, the risk for pneumocystis and other molds like aspergillus as well as bacterial infection goes up in these patients. So CT scan is very critical in helping guide your next steps.
Yeah, so we have put up the CT scan of this patient, if you can see in the screen. So it has bilateral ground glass opacifications and bibasal consolidation, and there's evidence of some cysts as well. Professor Brian Angus, would you be able to comment on the HRCT findings, and how would you think about the differential diagnosis that we had?
Yeah, I mean, this looks very much like PCP. Again, very typical widespread ground glass appearance. And the cysts, as I think people forget, pneumocystis is named pneumocystis because it's associated with cysts. So yeah, all this is entirely consistent with PGP. I think, as I say, sometimes interstitial infiltrates, people get a little bit confused with cardiac failure in these patients, but as I say, the ground glass, I think, is pretty typical of PGP.
Yeah, and from the investigations, Chanaka, if you can go to the previous slide. So the PCP, sputum PCP, PCR has been positive. And in the day 5, I think it's due to the delay in our system, we have got a blood CMV PCR, which is positive. It's 2,000 copies per milliliter. Prof. Angus, how do you interpret the CMV? Do you go for a usual cutoff, or do you look at the trends?
Yeah, no, I think it's important to look at the trends. Can I just comment about the sputum PCR as well for PCP? Again, BAL is higher sensitivity. So if the sputum was negative, in this case, I think you're strongly suspecting PJP, then you would probably go for BAL. Often it's not possible because the patients are very hypoxic, but we would try and get a BAL as soon as the patient was fit enough for it. As far as CMV, that level is sort of slightly raised, but not massively raised, and I think it would be in the context of what had been happening before with CMV. She mentioned it was negative 3 months before, so it's something that you've got to take seriously in someone who's unwell. And again, as mentioned before, people can have more than one infection, and so you want to give the patient the best chance. So certainly, I think you would go on and treat both for PGP and CMV.
Yeah. Also from Prof. George, can I ask how would you, start the initial treatment in this patient, looking at the investigations? Now you have a sputum PGP PCR positive, and also a CMV, kind of a low viremia, and also the chest X-ray infiltrates.
Yeah, so I think so far we have identified objectively 2 pathogens. One is CMV and pneumocystis. I think the predominant pathology in the lungs is from the pneumocystis. And we discussed the reasons why CMV may not be that important a player causing CMV pneumonitis as such, but it's something that could still happen. So the first thing to approach is you have already stopped the antimetabolites, MMF, And that's a good step because you do have established infection and you should discontinue that for the time being. Second, obviously, from the immune suppression standpoint, you want to make sure your TACRO levels are not too high because of the risk of promoting CMV and other things. But nonetheless, I would start off treating this patient for pneumocystis with trimsulfa-sulfamethoxazole in the usual dose, which is 15 milligrams per kilogram in divided doses 3 or 4 times a day, together with steroids. Even though this patient, there is some controversy and they all immune suppressed, but steroids is indicated. And typically we would start it at about 80 milligrams for 5 days, then taper down to 40 for 5 days, and then 20 for 11 days, and then go back to the levels that he was on for maintaining as anti-rejection prophylaxis. As far as the CMV goes, I would start treatment doses, which is 900 milligrams twice a day of valganciclovir, adjusted for his kidney function. So it's important to start and then monitor the CMV levels maybe a week after this, keeping in mind sometimes you will see a paradoxical increase in the second week before the levels drop off to 1 log or more, which will tell you. And I think it's another discussion is what to do. Typically, if there's end organ CMV disease, these levels don't taper down that soon. It takes at least 3 weeks of treatment, and then you'll have to decide, am I going to give this patient secondary prophylaxis or just continue to monitor the CMV? So I think the initial approach should be directed towards this. I would say by now, if it's day 5 or 6, and you've not had any bacteria grow in the state, it would be important to also think of de-escalating our antimicrobial coverage because of the concerns for not only C. diff and antimicrobial resistance, but just because it's not necessary at this point.
Yeah, next question I would like to ask from Dr. Chula Herat. What are the principles of adjusting the immunosuppression in this kind of patient at this moment?
Yes. There's no hard and fast rule on how to reduce immunosuppression. Certainly we have to reduce. It depends a lot on the time period after the kidney transplant, as well as the induction therapy he got, whether he had recent episodes of acute rejection, and what the recent blood levels of drugs like tacrolimus. Because this patient got ATG usage as induction, and sometimes T cell suppression goes on for a very long time, I would take off the antimetabolites, that is the mycophenolate, or if he's on azathioprine, take off azathioprine, and maybe reduce the tacrolimus levels. His previous TAC level was 6.5 usage. That was quite acceptable, not too high also. And I will reduce the tacrolimus to he's on 2 milligrams PD, yeah. Maybe reduce it to about 1 milligram twice a day, and maybe recheck the TAC level a little later, maybe about 4 or 5 days later. And of course, increase the steroids because for the pneumocystis. That's what.
Yeah, and from Prof. Brian Angus, can I ask the importance of the de-escalation of the antibacterial cover here? We have started on meropenem and teicoplanin at this moment. How long would you continue that, and what are the principles that would you use to de-escalate from there?
I mean, I'd say it is reasonable when someone's unwell and say you have to really start empirical therapy because patient can deteriorate quite quickly when immunosuppressed. But I think with negative cultures, we should get sort of 48 hours, probably 5 days would be the time if everything was negative to stop the antibacterial. And remember, of course, you've got Cotrem on as well, which has lots of antibacterial activity as well. So yeah, I would try and clear things a little bit by stopping the antibiotics. The other thing, of course, is that being on antibiotics does predispose you to further fungal infection as well.
Yeah, and next from Prof. George, I would like to ask, now we are giving cotrimoxazole to this patient, and the renal functions, has it increased with your management? Yes. Yes. And so how can we, think about the cotrimoxazole dosing, and also about the CMV treatment as well? And do we have to consider IV treatment with ganciclovir, or valganciclovir is enough at the moment?
I think it depends on how sick the patient is. If the patient is able to tolerate oral therapy and keep medications down as a functioning GI tract, since we are not considering CMV pneumonia as an important thing, it's okay to give oral valganciclovir. Now, if you had gastrointestinal disease, sometimes we start with IV because the conversion of the prodrug into this occurs in the lining of the gut, and that might be inflamed, so it might be suboptimal. It's mostly theoretical. But in this gentleman, it all depends. Is he able to take things orally? If in case, I would be perfectly happy dosing him oral. As far as cotrimoxazole is concerned and management, the same principles apply. If you're giving it oral, it has to be dosed appropriately. But in someone who's so sick, I might initially start off with IV therapy, though you do run the risk of fluid overload and pulmonary edema and things like that, because it does take a high burden of fluids when you administer IV trimethoprim sulfamethoxazole. So the short answer is it all depends on, is the patient able to swallow and absorb the drugs? There is no nausea, vomiting, diarrhea, in which case it's perfectly okay to give the valganciclovir orally.
Yeah, thank you so much. Chanaka, could you brief what happened next to your patient?
Yes. So, as Prof. Alan said, we started cotrimoxazole. The issue was there was an ongoing draft AKI, so we had to adjust the cotrim dose according to the renal function and the potassium level, because we all know the cotrim well known to cause the hyperkalemia. We started oral valganciclovir because he could eat, and there was no evidence of CMV enteritis. There was a significant improvement over the next few days. There was improvement in the numbers of CRP, white cell count has come down, and there was a significant improvement in chest X-ray. But on day 7, there was again clinical deterioration, increased oxygen requirement, and inflammatory markers has gone up again.
Yeah. So this patient initially had a clinical improvement, and the biochemically also it has been shown that the patient is heading in the right direction. But on day 7, the patient is deteriorating. Prof. George Alangaden, what do you think now? How can we approach this kind of a situation where the patient is deteriorating after initial improvement? Should we think of different causes at this stage?
Yep. And I think, if I believe, the X-rays also showed improvement. Is that correct?
Yes, and the X-ray initially has shown some improvement with the treatment.
Okay. So I think, it's important also in these patients to consider non-infectious causes. So one of the things we worry about once patients get into the hospital is pulmonary edema. They get short of breath because they get a lot of fluids as part of their management and resuscitation. The second thing is, even though typically we would put them on some DVT prophylaxis, you still have to consider pulmonary embolism, which can acutely make you sick. So non-infectious causes are also important to consider in these patients. But coming to the infectious part of things, like we said, many infections can coexist. So this patient initially improved with treatment directed at pneumocystis and CMV. We do know that CMV increases the risk for both other fungal infections such as aspergillus, molds. It also increases the risk for bacterial infections. Now, certainly you have to look for line-related sepsis, urinary tract infections, other things that could be driving this, or maybe a secondary bacterial infection with a multi-drug resistant bacteria such as a carbapenem producing Enterobacteriaceae. But that aside, which can be detected through blood cultures and other tests, we have to consider other pathogens. So when we think of other pathogens in this window of 3 to 6 months, what comes to mind is aspergillus, most commonly among the mucor. In my part of the United States, we would also think of histoplasma. Other parts of the country, if you have blasto, cryptococcus also shows up, though cryptococcus in the lungs is unusual, but it can certainly be considered. But I would keep aspergillus top of the list. You would also consider nocardia. Now, nocardia classically presents like a bacterial pneumonia, but it can have many different manifestations. The reason I'm not considering that so much is the patient is on treatment with trimsulfa, sulfamethoxazole, which is a treatment for nocardia, and also toxoplasma. Sometimes we have seen cases of toxo show up, but this patient is again on trimsulfa, which is a treatment. Could this be MTB? We have a gene expert that's negative. It's a bit uncommon, this presentation, and the X-ray would have shown worsening rather than temporary improvement and so on. So I'll keep that in the back burner. And then finally, strongyloides infection. We are given a whole lot of steroids. Are we causing a hyperinfection? And these larvae are migrating through the lungs would be one consideration. But the X-rays look quite dramatic when you have strongyloides migrating to the lungs, including pulmonary hemorrhage and so on. So in short, I think we should consider the possibility of non-infectious things like pulmonary embolism, pulmonary edema, but also keep in mind he could be at risk for other modes. So at this point, I think we have gotten another CAT scan and you can see the nodules that are surrounded by a halo. In my experience, it's a bit atypical seeing such a rapid evolution within 7 days, but nonetheless, he does have features of an angioinvasive mold. Most commonly, this is aspergillus, so you have obtained a sputum galactomannan, which is positive. So I think we have to consider this patient has invasive pulmonary aspergillosis with that high optical density number in the sputum and direct your treatment to aspergillus as well, the drug of choice being voriconazole.
Prof. Brian Angus, can I ask how would you, is there anything else that would you do at this stage? And when you look at the HRCT findings, and how would you interpret the galactomannan as well?
Yeah, as I mentioned, the sensitivity of sputum testing is lower than BAL. So I think, it may be that you've missed the window of opportunity where the patient was better and fit to get a BAL, but really that would be the thing to help with the diagnosis particularly. Galactomannan is a little bit difficult to interpret as a diagnostic test. It's much better for a monitoring test, but certainly in this instance with the halo side and the nodules and a clinical pattern that's consistent with aspergillosis, the galactomannan certainly helps to shore up that diagnosis. But as I say, I think it's quite important. Bronchoalveolar lavage is really the test that's really important in these sort of patients.
And as you discussed about a case of nocardiosis as well, what would you think the typical appearance would be in this kind of situation? And is it common to have the blood culture positives in nocardia?
No, blood culture positivity is rare in nocardia. Certainly having nodules, as we saw in the case that I presented, often with cavitation. But again, BAL would usually be the diagnostic investigation of choice in order to see the acid-fast bacilli. Yeah, as I say, I mean, I agree that this would be slightly unusual to have PCP, CMV, and aspergillus all within the course of a week. But again, with immunocompromised patients, these things happen.
In a patient with in this sort of a nature, if thinking about aspergillus and having even if your nocardia diagnosis is also on the cards, how would you try to differentiate that? What are the steps that would you take to differentiate?
Well, I mean, there's a sort of principle in infectious diseases. You look for a target. If you find the target, you biopsy it. And you look for evidence of the infection there. So really, as I say, often we'll ask our radiologists if they can biopsy these lesions to see what's happening. But again, just say again, BAL would really be helpful to differentiate between the two. Sorry, just to mention, you can get false positive galactomannan as well with PCP. The other thing just to mention is that resistance, antimicrobial resistance in PJP is almost unheard of. CMV resistance to Valgan, rare, but does happen. But as you know, it looks as though this is a third pathogen in this patient.
Yeah. So Chanaka, could you brief what happened next to your patient?
So with the further duration, we had to start the IV worry. The issue with IV voriconazole was, one thing is the TAC dose. There is a significant interaction with the TAC, so we reduce the TAC dose further, so from 1 milligram twice a day to 0.5 milligram twice a day, and we monitor the liver function very frequently every third day. And Cotrim dose further adjusted because there was an ongoing acute kidney injury, so Cotrim dose further adjusted. But with the worsening of the graft AKI and the hyperkalemia, we first reduced the Cotrim, then temporarily stopped the cotrimoxazole. So alternative to the cotrimoxazole, so we went ahead with the IV clindamycin plus chloroquine. Actually, we didn't have the primaquine, so alternative primaquine, chloroquine as an alternative, the unavailability of the primaquine. And with the recovery of the renal function and the potassium level, later we reintroduced the cotrimoxazole.
Yeah, can I ask another question from Professor George? And so now the patient is on treatment for PJP pneumonia. The patient is on oral Valgan cyclovir. And now we are attempting to start adding antifungal cover with to cover the aspergillus. So we are trying to cover many pathogens here. How can we rationalize our treatment at this time? Because sometimes it's overwhelming. How long should you continue, and what should be stopped? How can we rationalize these decisions at this moment?
So the key here is, what is the duration of therapy for all of these things? So in short, the treatment for pneumocystis is generally 21 days. So after that period of 3 weeks, you would certainly stop that. And then you will have to make a decision based on his kidney function, signs of rejection, whether you would continue with some form of prophylaxis for pneumocystis based on his level of immune suppression for another period of maybe another 3 months. As far as the CMV is concerned, the management would depend on both the CMV levels when you do it weekly. Typically, it takes between 2 to 3 weeks for the CMV levels to become undetected. And if you have 2 consecutive negative CMVs, you can stop your CMV and then do monitoring bi-weekly, every 2 weeks for CMV reactivation in the blood. Alternatively, some centers might say, this patient is high risk of severe immune suppression. Maybe I will want to continue valsite prophylaxis for another 3 months. But given the cytopenia and other things, it's something, and where the patient lives, logistically, sometimes that's easier to give them another 3 months rather than calling them back for testing every 2 weeks. So that would be something to consider. But 2 negatives, then you have to make the decision for secondary prophylaxis versus monitoring. As far as the management of aspergillus goes, the monitoring is mostly radiographic and clinical. There is some data to suggest that you could monitor the sputum galactoman and if the serum was positive, but it's not that commonly used in clinical practice. So most of the studies of invasive aspergillosis end up treating these patients for something between 8 to 12 weeks. And you'll be monitoring the patient using serial CT scans to see whether it's resolved, or it's reached a point where there's no further improvement. And at that point, typically we would stop the antifungal prophylaxis unless the level of immune suppression is intensified significantly, in which case the patient needs to be monitored closely. So I think, 21 days, you'll be off the pneumocystis therapy, CMV, maybe 3 to 4 weeks, you'll be off. And then aspergillus would take about 8 weeks is when we would typically do a repeat CT scan to see and make that decision. And then keep the immune suppression as minimal as possible if you can, while monitoring his transplanted kidney.
Yeah, one last question to Dr. Chula Herat. So now the creatinine is increasing, and what are the concerns? You have to protect the kidney now.
Yeah. Now he was on cotrimoxazole. Now we have to remember that hyperkalemia caused by cotrimoxazole is induced by the blockage of potassium in the renal tubules. Not only does it block potassium, it blocks creatinine as well. So with trimethoprim, the creatinine can go up to about maybe by about 20 to 30 micromoles. But in this case, it's a little bit more. But we have to remember that he was on IV voriconazole which increases the tacrolimus levels. So we'll have to recheck the tacrolimus levels to see whether the cause is cotramoxazole or whether it's TAC toxicity. So those are the two things that I can think of. Now, when you have hyperkalemia like this, obviously you have to take the cotramoxazole off, and I was a bit concerned about chloroquine. I don't know how effective it is with clindamycin. It's sad that in like a previous malarial country like Sri Lanka doesn't have primaquine now, right? So as soon as possible, we have to restart the cotramoxazole. Right?
Yeah, thank you. And Chanaka, we are reaching the end of the session. Could you summarize the learning points from this session?
Yes. So today's topic is infections in the immunocompromised. So any patient with immunocompromised like solid organ transplant, chemotherapy, there should be high suspicion of opportunistic infection, especially with the background of these chest x-rays, PJP in post-transplant patient with hypoxemia and bilateral infiltrate. Most importantly, we should modify the immunosuppression during the period of infection, and there should be a balance. We need to cater with the infection, and we need to protect the kidney. Entertain the broad differential diagnosis, and rather than putting all the antibiotic, antifungal, antibacterial, then the anti-TB. So we should be very cautious on putting all the arms together. MDT approach to treat infection in immunocompromised is extremely vital. And mindful about drug-to-drug interaction, especially when you are playing with the tacrolimus, because these drugs, some drugs increase the TAC level, some drugs reduce the TAC level. So that is extremely important.
Yeah, thank you. With that, we can conclude this session, and I would like to thank all the panel members of the panel, and especially Dr. George Alangaden joining us virtually, and Dr. Brian Angus, and Dr. Chula Hira. And thank you very much, Professor Lakmal Fonseka and Chanaka Abeyratne for excellent presentation, case discussion and presentation. Thank you very much. I would like to invite my co-chair, Dr. Ananda Wijewickrama, to deliver a token of appreciation as well as certificate of appreciation. Thank you.
Could I now please invite Dr. Ushani Varya Peruma to award the certificates and letters of appreciation to our chairpersons.